Bismillah ar-Rahman ar-Rahim. Sallam alaikum jami'an. Good afternoon, everyone. On behalf of the Continuous Medical Education Department at King Khalid Eye Specialist Hospital, I would like to welcome all of you today to the Visiting Professor Lecture. I'm sure that it will be interesting to all of you. We are delighted, Professor Ahmed Sallam, to have you at the King Khalid Eye Specialist Hospital. Thank you very much for accepting our invitation from Continuous Medical Education Department. We hope you enjoy your stay at Riyadh. This activity is accredited with for CME. I would like to thank all the members of Retinal Division at King Khalid Eye Specialist Hospital. And now we'd like to ask Dr. Hassan Al-Dibi to introduce our visiting professor today and to moderate his lecture. Thank you.
Yeah, thank you, Dr. Huda. And good afternoon, everyone. This is really a great day that we have a lot of activities from anterior segment, from retina. So I would like all of you to welcome Professor Ahmed Sallam. He's our visiting professor from the United States. Professor Ahmed Sallam, he's very active, teacher. He is professor of retina and uveitis, director of uveitis service, residency program directors, and he's a clinical research director at University of Arkansas for medical science. In addition to that, Dr. Ahmed is very active, authors. He's having more than 190 publications in the indexed journals. In addition to that, he's actively participate in the training, teaching, in the residency program of Arkansas. I would like to welcome you without any ado for that, and I would like all of you to welcome Dr. Ahmed for this grand round.
Well, thank you so much, Dr. Hassan, for the kind introduction, and thank you so much all for the kind invitation. I'm so delighted to be here, and honored and humbled to be here, and thank you, Dr. Hanan, as well. Again, I'm originally from Egypt, so this is for me here is like second home, of course. And thank you so much. So I know there's a mixed audience there, so I try to choose the presentation to match mixed audience. I feel I'm a bit disadvantaged coming to present after Kamran, who's a fantastic, really, a speaker. But anyway, I'll deal with it. And Kamran is a great friend. He's a few hours away from me, and we're good friends. So I thought maybe a nice talk for a mixed audience would be the intersection between retina and lens, and this is actually one of my areas of research, as I'll tell you later. And I feel that the interaction between the lens and the retina is really like a very deep and complex interaction, rather than just again, no offense, cataract people dropping the nucleus and we are dealing with it. I think it's more complicated than this. So for example, if you look like cataract surgery and you have kind of problem with cataract surgery, as you can see in figure B here, and also if you do uneventful cataract surgery, you get vitreous changes, posterior vitreous detachment, what we call endodenesis, and you get retinal detachment, or you do vitrectomy for whatever indication, and that vitrectomy changes the oxygen tension in the eye with more oxygen delivered to the lens, and you get post-vitrectomy cataract. It's really a very complex interaction, more complex than what I'm saying. So, and again, you can look at how the oxygen concentration in parts of the eye changes after removing the vitreous, as you can see in figure 3. There's more oxygen delivery going on to the front of the eye after removing the vitreous. So for this talk between the lens and the retina, I divided into parts. I'm trying to reflect on the things I've done. So just like a self-reflection and also discussing other things. So first we're going to discuss how vitrectomy causes cataract, and also then cataract surgery in certain retinal disease where we studied, and then combined versus sequential cataract, and then we can discuss some retinal complications of cataract surgery. Please feel free to interrupt me with questions, because I think that will make the talk more interactive and adds more to the discussion. So post-vitrectomy cataract surgery, what do we know about this? We know that actually when you have vitrectomy, nearly 100% of the patients, if you're over the age of 50, you get cataract surgery. So our point is, how do these patients do post-vitrectomy cataract compared to routine cataract surgery? So we did this multi-center study, having data mainly from UK, and it's about 140,000 eye. And we found that actually a good number of these patients do improve in vision, but compared to like routine cataract surgery, they are less. We thought that if you operate on a patient who had vitrectomy, you have a higher risk of posterior capsular rupture, but actually that was not the case. And other also authors in different series, they did not find this. But one thing which is actually consistent between studies, something to be wary of, is that these patients have higher risk of zonular dialysis. And especially with the new technology now, and we're doing more peripheral vitrectomy, we see better, we end up eating some in the zonules. And remember that the zonules are connected to the vitreous, the posterior zonules. So just be wary when operating on these patients that had vitrectomy before, that the risk of zonular dialysis could be higher. And that's actually what we found. Moving on again on the same thing of post-vitrectomy cataracts, diabetic patients are always disadvantaged in everything, except one thing, that if you had cataracts, if you had vitrectomy surgery and then in a diabetic versus non-diabetic, the risk of, or the likelihood of developing cataract is actually lower in diabetic. And that has been intriguing for several times. And if you can see here on the survival curve, the red one are the diabetic ones. So the risk of coming to cataract surgery is actually lower. And they did cataract surgery at a later time compared to non-diabetic. And this is independent of the age. And the reason is the diabetic eye is hypoxic eye. So even if you remove the vitreous, the less oxygen is delivered to the lens compared to if you're non-diabetic. And we found that actually, interestingly, it matches with the degree of retinopathy. So less cataract if you have proliferative retinopathy. So what's the implication of this in our practice? I think there is good implication. Like, for example, if we retina surgeon operating on patients with clear lens, diabetic patients, especially the young ones, there's no need to remove the lens and make things more complicated, because the risk of developing cataract is lower. And sometimes, especially the young ones, they end up not developing cataract for a long time. And that's what we found, and it's mainly related to the oxygen tension. Okay, now we can move on to the next one, which is interesting, cataract surgery in patients with primary epiretinal membrane, or cataract surgery in patients with retinal disease. The first one, which is very common, is primary epiretinal membrane. We were interested to see if you have patients who have epiretinal membrane, primary epiretinal membrane. Does doing the cataract in these patients, if they don't have significant distortion requiring combined surgery, do they improve? And actually, they tend to improve well. And in a lot of patients, they did not require vitrectomy, maybe 10% required vitrectomy. But something to know that the cystoid macular edema risk of these patients is very high, and we found it actually to be 8 times higher. So again, what's the implication of this? The implication actually is, if you think about it, is soundful, because as we get older, we get cataract, and 7% of the population over the age of 70 would have epiretinal membrane. So it's actually a big number of patients. So unless these, yeah, thank you so much. Yeah. Any chocolate? So a good number of these patients would have cataract as well. So unless they have significant distortion, just go on, as for the cataract surgeon, just go on and do the cataract. And then if things get worse, you can deal with that later. But we found actually, unless they have like a significant indication for vitrectomy later on, a good number of them may not have may not need vitrectomy surgery. But be wary of cystoid macular edema. And I would not recommend like a prophylactic treatment for cystoid macular edema for everyone, but that's a group that you can give them topical non-steroidals as well after the surgery. For secondary epiretinal membrane, we found very similar reads. CME rate is higher, even higher when you have a secondary epiretinal membrane. Now the question is, what happens in patients with wet macular degeneration requiring cataract surgery? Again, and we found what we expected, that their vision does improve. So if they have cataract, do go ahead and do cataract surgery. Of course, not as good as routine surgery. We found that, as you know, that posterior capsular rupture can be higher if you had many injections beforehand. I'll show you that in a second. Because you may be actually causing rents in the capsule as you do the injections. We found something interesting that we did not expect. And again, several group also found this, that cataract surgery does increase the number of injections, which actually maybe like the inflammation caused by cataract surgery, it increases the activity of the neovascular membrane. Something to be wary of if you're doing injections for patients with neovascular AMD, they get cataract surgery, just be wary that they may become more active and we need more injections. And we found that a high risk if you had 10 or more injections, you have a high risk of developing posterior capsular rupture about 2 times. So just be wary when you're operating on these patients, examine the posterior capsule before the surgery, look for lines there in these patients, and if they have these lines, the risk of posterior capsular rupture is higher. Again, going on, that's something was intriguing as well for us. Do patients with retinitis pigmentosa improve after cataract surgery? And we found that they do improve. Of course, the vision is not really as good as routine, but they do improve. So if they have significant cataract, go ahead and do the cataract. One thing which we found very interesting is the CME, but even more interesting is their capsular, and they tend to get much higher rates of YAG capsulotomy. So it developed posterior capsular opacification. So something to be wary of. What happens in vein occlusion? We found really what you would expect, that again, CME risk is higher, and they do improve the vision, but still is limited because of their disease. In that group, interestingly, the PCR rupture rate was not higher. And when we looked back and reflected on this comparing to diabetics and AMD, I think the main thing is really they don't get as many injections as diabetics and as AMD. And maybe that's why the risk of posterior capsular rupture was not higher in these patients. Okay, what about diabetic surgery? I know, lots of, in the Middle East, lots of diabetes. We found something very interesting, that your vision after the surgery is actually dependent. And in this group, we excluded patients who had diabetic macular edema before, but we found something interesting, that your vision after the surgery is dependent on your vision before the surgery and also the degree of retinopathy. So I'll give you an example here. So this is like a 0.3 logMAR, and we know that on the logMAR things are reversed. So if you have a high logMAR, means worse vision. And if you find 0.3 logMAR with those lines down there are like the milder retinopathy, you reach to really good, very good vision. But if you operate on the same vision but a worse retinopathy, your yield in the vision is lower. So again, the message from this is go ahead and operate on these patients early if they have significant cataract. Don't delay them until their vision is worse and their retinopathy is worse. They may not benefit as much. And as you would expect, and as we discussed before, we found that actually the very important risk factor is the number of injections for posterior capsular rupture, in addition to other things. But diabetes itself was an independent risk factor. Hard to tell why. Maybe the pupil, although we looked at the pupil, it's just hard to tell. But these cataract surgeries are more difficult than others. You get small pupil. Usually their cataracts are denser because they have been left and not being operated on, and also more important, the number of injections. So when you examine these eyes, always look at the posterior capsule for any like linear lines there. I can stop here for a second if you have any questions, just to make the talk more interactive. Yes, please. Thank you, Rola.
Zone do worse after cataract surgery. They improve temporarily, but then for some reason, actually, it speeds up the progression of the RP to involve the macula much faster.
Oh, interesting.
Yes.
Is that something recent? I'm not aware of that.
Yeah, so I became very selective. So I would recommend cataract surgery for those who do have decent ellipsoid zone in the fovea at least. But those with partial atrophy or early macular involvement, because we do have quite a few genotypes that are associated with early macular involvement much faster even progression than what I've seen in London or in Toronto. So what's your take about that?
Yeah, I mean, to be honest, I'm not aware of this. On this paper, Michael Michaelidis,
yes,
again from Morphos, was on this paper as well.
Yeah.
He was one of the co-authors, and we did not see this. I wonder if the worsening was due to cystoid macular edema getting worse, because again, like in uveitic patients, that's the most common cause of worsening after uveitic cataract surgery, but I was not aware of this. We did not see this. It's interesting.
Well, yeah,
and I think worth considering.
I remember when I used to work with Andrew Webster that we only, selectively refer patients that we think they are gonna fare better. So that probably explains the outcome.
Yeah, and also like the data from other groups as well showed the same as well, but I'm not aware of this.
Thank you.
Yeah, of course. Okay, well, let's... Okay, all right, sure. Let's go for, so what happens, again, cataract surgery and retinal disease, if we can finish with uveitis. And again, I thought just include some surgery to make it attractive. Uveitic cataracts in general are, I don't find them difficult cataract as long as you've passed the pupil problem. After that, it becomes easy. So it's mainly the pupil. And that can be difficult. In the old days, I used to like peel all this pupil membrane and it feels very nice, but then they get more inflamed. So nowadays, what we tend to do, although we don't have a formal study on this, is try to make an opening and just open it and then leave it. And this is actually a very interesting case. And again, it's one of the benefits of being in a teaching institute. This is actually my senior resident operating this case. So like an R4 equivalent. And here we couldn't get, so we went through the PI to have like access because we could not open this membrane. And then after that, you stab it with the MVR. And then we just cut it open. And after this, you put a malusion ring. And that's what I tend to do nowadays. I just try not to peel them off. I just try to do the minimal. And I find that pays better and they have less inflammation in the eye. And again, I was really so impressed with all the setup here and the technology. And we are in Arkansas as well. We're very much into the technology. I think it gives an amazing chance for residents and fellows to train. So definitely kudos for all the beautiful setup that you have. And again, here, and then we end up usually with Ozurdex. I quite like Ozurdex in cataract or retina surgery. We looked at patients with uveitis needing retina surgery. And the Ozurdex was actually associated with less improvement. Just be wary if you're injecting it in the eye, because as you can see here, it just shoots in the eye like a bullet. Usually nothing happens, but it's very interesting as it shoots inside the eye. Is it possible to dim the light a little bit? Is it possible to dim the light for the IT? ممكن نوطي النور لو نقدر نوطي النور شوية عشان بس الصور تطلع. Okay, what about, again, changing gears to complicated issues and eye disease? What about cataract surgery in extreme axial lens? Again, if you speak to cataract surgeons, and if you look at the literature, they tell you that extreme axial lens is a problem and they are associated with problems. And that's something really that, again, intrigued me for a bit because is it really a problem or it's just they have comorbidities and most of the series did not exclude comorbidities. So I'll come to this in a minute, and that's what we found. But it's a more like, for example, operating on hyperopic eyes is difficult because the eye is like so crowded. So yes, there are technical difficulties for sure. And that's one of the things, and I think operating on hyperopic eye is more difficult than myopic eye for sure. Myopic eye is usually not that difficult. So something again from retina, which I find very useful, is to do a limited vitrectomy in patients who have very shallow eyes. So here, and that works very well for phacomorphic glaucoma, for example. This is a very shallow eye and was referred to the retina service because they said it's very difficult and they will not be able to do the cataract, so maybe the lens would fall, so it's better that we deal with it. And here we're trying to do a capsulorhexis, but even there's no space. So doing going pars plana and doing a limited vitrectomy in these cases makes things much better. As you can see, you just go with the cutter and draw some vitreous until you get a little bit of infolding of the cornea. That's the end point. And then the AC becomes so deep. And I found that a useful tip in crowded eyes. One other tip again from retina is that with retina you don't get like iris prolapsing or choroid prolapsing, and I thought of this as we were operating patients with crowded eyes and floppy iris. With hydrodissection, you got the iris everywhere because of the crowding or the floppiness of the iris. So something that we thought of, what works very well in these eyes is to do the hydrodissection from the side port and have the phaco tip there as a conduit to shift the fluid out. So you're blocking the main wound, and at the same time you're having a conduit for this fluid. And we've operated so many patients like this, and a little bit of a difficult technique because you're using one hand to inject, but the iris prolapse does not happen. And I find this very helpful in crowded eyes and floppy iris. Okay, what did we found in extreme axial lens? We had a group of eyes where we actually divided them into 3 groups, and in the extreme eyes group we had really good eyes, number of eyes about 9,000 there and 5,000 in the long eye group, and we excluded every comorbidity you can think of, like small pupil, everything, and we had a very clean group. And then when we looked at that group, the vision acuity changes was not different between the two. And the complications that were different was not PC rupture, but was retinal detachment in high myopic, as you would expect, and torn iris in very crowded eyes, again, because of the difficulty of access. Otherwise, there was really nothing significant. So, and I think this is one of the nice things about big data, is that you can really exclude things that may contaminate your outcomes, because most of the short series there would have, like, for example, including patients with comorbidities. But again, one of the things with big data is that you can really get very nice outcomes. And again, you're so privileged here. I mean, you have amazing data, an amazing number of records, really. So I think that's a great potential for fantastic publications. Comes to the next point, which is what happens with combined versus sequential cataract surgery. And I remember when I was a fellow and then I came on to become a consultant, I used to do lots of combined surgery, and I thought it's very nice to do more and get things finished. But as you do more, you think, is this more inflammatory to the eye, or it's actually you're more making like or that's actually the way to go? Because especially that for hospitals and for patients, if patients are paying, you are saving them money. I mean, you're doing 2 surgery for the same of one, for the price of one, so you're definitely saving money. But is that like good or bad? It's hard to tell, but this is like my take on it. Again, something here for people who are doing combined surgery is best to do trocars first. The eye is the eye is actually firm, even one trocar there. Here, if you try to do it after cataract surgery, that happens, and the eye, best not to operate on a hypotenuse eye. So always put at least one trocar first. And then you want to get the wound nice there, not too long, is one of the important things. The rexes, don't make it very big, because that helps, especially if you use gas, as I'll tell you later on. And then phaco, use your way, but don't bring the lens up to the front if it's hard, because the pupil is gonna close, and you don't want that, and the cornea is gonna get worse. So if the lens is hard, definitely tackle it at the back of the eye. So don't do that, because you get the pupil to close, which could be a nice technique for soft cataract, but not for hard cataracts really. And then you want to finish without hydrating the wound, and after that go for vitrectomy surgery, and then you hydrate at the very end. Okay, so what happens in simultaneous versus sequential cataract surgery? This is, we decided to look at all patients who are combined versus sequential surgery. And we had nice groups really. Out of 200,000 eyes, we looked at patients who had combined surgery versus sequential vitrectomy and cataract. And we ended up with about 2,000 in each group. And what we found is, we found that visual acuity at the end is comparable. But if you think about it, patients who had the combined, they get the vision to recover slowly, because you're dealing with a retinal problem and a cataract problem, so that takes time. While if you're doing sequential and you've done the vitrectomy first, then the retina has sorted itself out, and now you're doing the cataract, so next day patients see better. So I think that has implications when consenting patients, that it will take time. It's not like the cataract surgery that your neighbor had. It's not like this, your vision is better if you're doing combined surgery, because the retina still needs to recover. Found interestingly that posterior capsular rupture during the surgery of combined was higher. especially if patients who had retinal detachment or vitreous hemorrhage. And I think it relates to the red reflex. If the red reflex is not good, you don't see well, you have higher risk of posterior capsular rupture. Cystoid macular edema was not different, but something very interesting, and it affected my practice, really learning from that. And it depends who you speak to. If you're like speaking to someone who is very pro or very keen on combined surgery, they tell you that doesn't happen. If you speak to someone who is impartial or don't like combined surgery, they tell you this is a problem, is IOL problems. And I find this to be a significant problem, especially if you're going to use gas, because the lens really a bit displaced, and that goes from like pupillary capture to even like decentration in the anterior chamber. And it's complex. I think it relates to inflammation in the eye, the size of your rexes, and also the use of gas. Because when we chopped in more in the data and we looked at the epiretinal membrane patients, that was not there. And I think the reason for this to happen is that epiretinal membrane usually is a short surgery, it's a quick surgery, and you don't use gas. So IOL issues were not there with epiretinal membrane surgery. So I think if you want to combine surgery, epiretinal membrane is a nice one to combine surgery in. But again, we found in both groups, sonioral dialysis is an issue. So just be wary that eyes that had vitrectomy, they have higher risk of sonioral dialysis. And again, came the question really, especially in the US, where sometimes the cataract surgeon is called in to do the cataract part of a combined surgery, which again, I don't think really it's beneficial for anyone, but that's how things happen there. Especially in private practice. In universities, they are not so bothered. So what happened, what happens in these patients is the cataract part of the combined surgery as easy as routine surgery. And we found actually, no, this is not the case. We found that if you are, we found that if you are doing just a standalone cataract surgery, your risk of complications is less. So there's 3 times higher risk if you're doing combined surgery. And again, especially with retinal detachment and vitreous opacity, you're dealing with an eye where the red reflex is not ideal. Of course, cystoid macular edema is also higher. Again, you're doing 2 surgery instead of 1. And IOL issues were there as well. So something to be wary of. And of course, the vision is very different. So if you happen to be that cataract surgeon, consenting is important because that patient, the vision is not going to be the same like a standalone cataract surgery, and also the higher risk. And you are being pulled to do a difficult surgery, so be prepared that your risk of PC rupture might be higher. And very important, suprachoroidal hemorrhage, your risk is like 45-fold higher, especially in patients with retinal detachment. And I think it's the hypotony. You're dealing now with a system where it's not like very closed, and you can get hypotony and changes in the eye if you're doing, for example, especially if you're doing retinal detachment surgery. Okay, and that's, so when do I combine vitrectomy and cataract surgery? I combine them in anterior PVR where you need to dissect. Epiretinal membrane is a very nice surgery, I think, to combine if you really want to combine. And just be prepared in long cases, and we're having a discussion with the retina service here, and I think that's people tend to do. If you have long case, at least be prepared that if the lens fogs during the case, you're ready to remove the lens. Because sometimes just you have to remove it to continue, so at least be prepared. And this is here again, just a quick show. If you have anterior hyaloid dusting with hemorrhage, that's one of the indications where you need to be ready to remove the lens if you hit the lens. And something again for the vitreous, for the retina fellow, when you're examining a case of vitreous hemorrhage, just make sure you see what's the relationship between the hemorrhage and the lens. It's not only the cataract, but how dusted is the posterior capsule, because that makes surgery difficult. And also at least be prepared with calculation of the IOL in case you need to remove the IOL, the crystalline lens. Okay, takes us to the last part and the most interesting part is the retinal complications of cataract surgery. So CME. So CME after cataract surgery, the rate in the normal or like uncomplicated routine case is 1%. So what happens in other patients? And if you look here, again, there are indications. And one of the important things that happens in diabetic patients. And there are I really like numbers, and I like to remember numbers and tell it to the patients. So if you have like a routine cataract surgery, your risk of cystoid macular edema is 1%. If you're diabetic, no retinopathy, and you're having cataract surgery, you're 2%. If you have non-proliferative retinopathy, you're 4%. And if you have proliferative retinopathy, you're up to 10%. And these numbers excluding patients who had any sort of macular edema before cataract surgery. So your real risk, even if you're just diabetic, is higher. And that, again, an indication for diabetic patients to do something to protect the macula. I usually, if they don't have really significant maculopathy or DME beforehand, I just give them Acular after the surgery with the steroids. If they do have macular edema, then I would give them anti-VEGF or steroids before or during or after the surgery. You have to stabilize the macula. So I think that's a good one. And then the other risk factors, as we discussed, PCR rupture is a risk factor, uveitis, epiretinal membrane, as we discussed. And these are other risk factors of macular edema. Comes the very interesting part, and comes the part why I'm in academia personally, is really the interaction with the residents and the fellows. And I have a very clever resident who's now my fellow. His name is Ahmed. He's originally from Iraq. And he's really a clever guy. And he came to me and he's saying, in all your papers before, you exclude second eye from analysis. Like if your patient had 2 eyes done, you exclude that, you don't include the second eye. And I was telling him because reviewers don't like this. And they say there's always correlation between a first eye and a second eye. The 2 eyes belong to the same patient, so you should not include them. And he said that during his residency, he saw that if you had a first eye cystoid macular edema, you're more likely to get edema in the second eye. I think that goes also with our feeling, right? That this patient is unlucky, right? First time, so he'll be unlucky second time. So he said, why don't we look at that? Why don't we look at the influence of the first eye cystoid macular edema on the second eye? And I thought that's very clever. So we controlled for all the risk factors that increase cystoid macular edema, and we studied the first eye cystoid macular edema as an independent factor. And actually that was so interesting that we found actually this is the highest. And you have about like 8 to 9 times fold of increase of getting cystoid macular edema, independent of anything else, independent of whether you had macular edema, whether you had PC rupture, your cataract was complex, your pupil was small, your surgery was done by the resident or the fellow or the attending. That's an independent risk factor. There's something in this patient. So I got excited and I told him, okay, well, thank you so much. I'm going to do another paper then without you. And I decided to look at the second eye cataract surgery with posterior capsular rupture. Is posterior capsular rupture in the first eye a risk, an independent risk in the second eye? And we found actually there's increase in 2-fold. Then I thought, okay, I'll take this further and look at zonular dialysis. And zonular dialysis was very interesting. We found actually there's about 14 times increase in zonular dialysis if you had zonular dialysis in the first eye. Is there something in your zonule that is weaker? And we found evidence that the capsule, posterior capsule, for example, it varies between patients. Is it something in you that was not captured in study and cannot be captured? For example, you have sunken eye, or you move during the surgery. You get anxious and you move. We don't know, but there's actually increased risk. And I think that has implications in teaching, allocation of cases. And it goes with the classic saying in the world of surgery that to do the second organ, if the first organ was complicated, it has to be a surgeon who's as senior or more senior than the first surgeon, because you want to try to avoid complications. So I think it goes with that. Then I had the idea, let's look at PVR in the second eye if you have had PVR in the first eye. But unfortunately, until I convinced this fellow now to look at the data, another group took the idea and they did it. So anyway, I think yes, there is definitely, there's something happens in this type of patient, and this patient compared to another patient. So I think this something needs to be considered. How am I doing with time? I don't want to go over time. Okay, right. Well, we'll finish before that. Okay, now the interesting part in cataract surgery and drop nucleus, right? So if you have a lens like this, you know that there's a risk of nucleus. And we wanted, again, for consent purposes, we wanted to see how patients do if they had drop nucleus. So again, we went and looked at the data of patients who had dropped nucleus, and we wanted to really get like nice outcomes. So how do the vision, what happens to the vision, what happened to the cystoid macular edema and retinal detachment? So in this data, we found that there's about 0.3% rate of dropped nucleus, and we classified the data into 3 groups. One group was a posterior capsule rupture only, no dropped nucleus. The other one was dropped nucleus, and the last one was like routine case. And we found that preoperative, maybe a little bit of more bias towards like the cases that are complicated, having a worse vision, which again, we know that advanced cataract is one of the risk factors of posterior capsule rupture. Actually, we had a calculator before, and if you have brown cataract, if surgery is done by a resident, and they have pseudoexfoliation and a small pupil, can you guess what would be the risk of posterior capsule rupture if you have all these? 100%. And actually, if it's done by consultant, it's 40%, which I think is very important. Because 4 out of 10, even you as a senior surgeon, you will have a PC rupture. So I think it's good to have these things and, you know, tell patients about this, because whatever they hear, whatever they don't hear before the surgery, it didn't happen. And it's best if they hear things before the surgery for consenting. And you'd be surprised, even for the non-educated patients, when you tell them in a way they can understand it, they appreciate that what you told them. Okay, and then moving on after the surgery, if you look at patients who gain vision, reaching to a level of 20/40, which is driving vision and good reading vision, in the reference group is about 85%, while actually in the dropped nucleus group and the posterior capsule rupture is low. It's about like, the odds of reaching that good vision is about 1 in 10, so it's about 0.1. So their vision, yes, the vision does improve, but they don't get there to like routine cases, which is something very important to keep in mind and to keep an eye on these patients. And one of the reasons really is a increased risk of cystoid macular edema in these eyes. And the other important factor as well is that later on they can get retinal detachment. And we found actually 4-fold increase in retinal detachment later on. And I think we were discussing this today with Dr. Ramsey during a case that I was doing, which actually was a dropped nucleus. Then one of the important things for the retina fellows when you're doing these cases is to examine the periphery. The reason you need to examine the periphery is you find retained lens matter, which you have to remove to get the eye to quieten down. And again, I go off axis here, but one of the reasons that if you have a posterior capsule rupture, the eye is inflamed after the surgery is leaving lens matter. And my advice, if you have posterior capsule rupture or dropped nucleus, remove every part of the lens matter and you'll be surprised how the eye settles down so nicely. So the message we give to anterior segment surgeon, if you drop the nucleus, what to do? Just don't do anything. Leave it. This is not a federal scandal. You have a team re-employed for this, and just clean the anterior segment and have some sort of, it depends on how the retina team would tackle the nucleus, whether or not you put an IOL, as I'm going to show you in a touch later. And then don't do it, because this is a case which was actually operated next door. The nucleus dropped and I was operating, and I told him, okay, I'll finish the surgery and take the patient. So I took the patient in and I went inside the eye, and this patient actually had a giant tear. So you would think that probably something like this happened. So no fishing in the gel. Just let it sit down, and this patient will do much better and will reappreciate you. But if you try to suck the nucleus, you'll end up in problems. So don't do that. Just let it and do a nice anti-vitrectomy and refer to the retina team. So the question is, what to do if you have dropped nucleus? And I'll show you something that we tend to do. So the classic is when you refer to the retina team, they, if the lens is soft, they remove it with the cutter. If the lens is not soft, then they will have to introduce the fragmatome. And classic is you introduce the fragmatome through the pars plana. It doesn't lend itself well to the nice transconjunctival vitrectomy. The only thing, other thing I don't like is a big instrument going through the pars plana. In the old days, we used to have entry site retinal breaks, lots of traction, as Dr. Hassan is saying. So I try to avoid this. So this is my technique, which we developed over the years, but then we found that another group described it as well. So it's one of those things. But we go actually through the limbus. And I operated a case like this today, and there's a little bit of a difficulty because the angle of attack is a weird angle of attack. But if you can manage that in the initial phase until you get the nucleus, it works so nicely. And of course remains the concern, can you get a wound burn? Which we did not find, as I'll show you. And S3 is very efficient. I use the phaco because of the Ozil technology. The retropulsion of the lens is very low, and it goes really very efficiently. And we operated a case like this today. And then after that you finish, and remember the most important to check the retinal breaks and entry sites. And this is again, if you have lens matter, remember to remove all the lens matter because you want this eye to quieten down. So we did the study comparing those two fragmentation technique, and we have two main surgeons in my hospital, myself and another surgeon who always goes through the parasplanner, and I always go limbal unless an IOL is there. And we found that there's no difference in wound burn. What we found is that you can get iris damage if the pupil is not small. So always make the pupil is small, always make sure that the pupil is big. But otherwise, wound burn does not happen. And if there is some people of my generation here or older, you remember that in the 2000s, something came in Europe called the bimanual phacoemulsification. I don't know if anyone remembers that. You were using irrigating chopper because there was the dream that you have an IOL that goes through a sub 2 millimeter. So you wanted to make like very small, yes. And so you have this irrigating chopper. And in this, they were using the needle like I was using it to do the regular phaco, and wound burns did not happen. If you don't have a very tight wound, wound burns do not happen. And that's what we found as well. But you need to make sure that the iris is big. And also you need to like adapt to it because the angle of attack is weird until you really get the hang of the nucleus. Okay, again, cataract surgery, retinal detachment, we talked about it. If you're more complicated, and actually if you're high myopic or posterior capsular rupture, your hazard ratio goes to 4 times. And then if you have posterior capsular rupture, it can go up to 13 times the risk. So remember something to remember that these patients, and that's what we found in this UK study, that the retinal detachments tend to be more the more you follow them up, and the risk can go up to 0.3% if you are at 7 years. So still it's not very high, but you need to really like make sure that you follow up these patients. And then if you're high myopic or posterior capsular rupture, then you have higher fold. I like numbers, and again for the residents who are here, the risk of retinal detachment in the general population is like congenital glaucoma, 1 in 10,000. But then when you have cataract surgery, at least it becomes 1 in 1,000. And if you have a PC rupture, it becomes probably like 1 in 100 or 4 in 100, just to remember the numbers. Okay, and last I just want to finish with endophthalmitis, and the question really is always intriguing, is post-cataract surgery endophthalmitis or post-procedure endophthalmitis, do a tap and inject or go vitrectomy. And the endophthalmitis vitrectomy study is an older study, and it tells you really do injections in these patients. And now many people are against that study now because they think we are like better surgeons, we have better technology, and we can see better, and the endophthalmitis did like minimal vitrectomy, and we're definitely better. So the argument is actually that, no, let's do vitrectomy, and just the endophthalmitis vitrectomy study doesn't hold. So the outcome of the endophthalmitis study, as long as you do not have like a light perception vision, there's no advantage of doing an immediate vitrectomy. But there are advantages that these patients, you need to get them in quicker. Not every center has a retina surgeon. So we did a study where we looked at, okay, what happens in the real world? And that's where you collected data from European retina specialists. And we wanted to see how they manage their patients. And we found that actually about 75% of the patients, they do not follow the endophthalmitis vitrectomy study. They do primary vitrectomy regardless of the vision. And in a way, I expected this because whenever we talk to people, they say, no, we're better surgeon, we have better instrumentation, we do immediate vitrectomy. And they always say, if it's your mother, what would you do? So I would expect this. The most important questions is how do patients fare, right? With all this like change in practice. So the report 2 of this paper is we looked at how do these patients fare. And actually we did not find that patients who had vitrectomy did any better. And in my view, the endophthalmitis vitrectomy study group, the endophthalmitis vitrectomy study results still hold. And that was replicated in a meta-analysis just came after our study, and that actually showed the same. And another meta-analysis as well showed the same, is quickly manage these patients with injections, don't waste time, and then we can talk. In fact, a very nice study from Manchester showed that actually you could lose these eyes more if you do vitrectomy. And vitrectomy in these patients is really a very difficult vitrectomy. You have to be very careful. You know, the eye is very necrotic. If you pull a little bit on the vitreous, you can end up with a break in these eyes. Usually you lose the eye. So I'd be very careful in these eyes. And the problem is really, this is here, the eye had cataract surgery. This is endophthalmitis. And as you're rethinking and thinking and you're trying to get this patient to the operating room, what happens is the eyes gets, these organisms, as time goes, they just keep doubling. And the doubling time with staph epidermidis, which is a very low virulent organism, is 25 minutes. So every 25 minutes you have doubled the organism. As you're like struggling with the OR, trying to get this patient in, and then you find infection disease telling you, actually there's an infected case, we're not sure, maybe let's just do it at the end, right? And then the patient is waiting and waiting and waiting, and you've lost a few hours, and now we're saying this is an emergency. So I would not do this, and the way to deal with this really is just get on and do injection, outpatient, then we can talk. And that's really what we found. So I think in summary, what I learned so far is honestly less is more, and this is really my belief. I think this applies for so many things. Simultaneous versus sequential surgery, endophthalmitis, retinal detachment surgery, TRD, and I think there's a price for the minimalistic surgeon. Just do the less, and I think less is more, and that's, in my thinking, it works so well. And thank you so much for bearing with me.
Thank you, Dr. Ahmed. It was really comprehensive, interesting, covered most of the aspects that usually in daily basis we are practicing, and that to highlight this some risk factors. So I would like, to open the floor for the, for the questions and comments, and we'll start with Professor Al-Fawaz.
Thank you, Dr. Sallam. That was a nice presentation, nice talk for us as an anterior segment and cornea surgeon. We learn a lot from this. Just I have one quick comment and one question. The comment regarding the fellow eye studies that you already did with the fellow, I think it would be nice also to test the efficacy of non-steroidals in those eye as a preventive measures. And then maybe we can have a solid evidence, because as you may agree with me, and maybe Dr. Kamran, we were discussing this earlier, that non-steroidal use in both cataract surgery is still not that strong evidence. That was the comment. And the question, now we are having a growing practice of doing cataract surgery in young patients in the 50s or in mid-40s to tackle the presbyopia and to remove some of the lens changes. Does that increase the risk of retinal detachment? Does there any risk of the retina you need to discuss with our patient? Thank you.
No, I think it's a great point, and you're absolutely right. Non-steroidals, so far, we think it works, it's important, but we're not seeing this in practice. So I think at least it needs to be individualized. I would not give it to everyone. So if you have patients with high risk, yeah, I think that's a good one, and I think it would be interesting to look at the effect in the fellow eye. As for the like clear lens extractions, we know that there's a definite increased risk in cataract surgery, at least from 1 in 10,000 retinal detachment to 1 in 1,000, if this is not complicated. If you're high myopic, right, you're 4-fold increase. Mm-hmm. So if you think about it now, so at least like probably 1 in 200. So there is a risk, and there's a risk in high myopic, and there's a risk if it gets complicated, and young male are more at risk of retinal detachment, so definitely there's a risk. The question is, do we do prophylactic laser? I would not advise this, and I think the whole, like my understanding of the whole literature, there's no need for prophylactic laser even for lattice. Mm-hmm. But you have to explain to the patient. I think it's important that patients understand.
Yeah, because the question would say, if I do it now in the 45 years old, does it differ if I do it in the 60 years old? The same patient with the same risk. Does it make a difference from retina point of view? Or
Yeah,
does it
I think they will get retinal detachment earlier. So most of them are not going to get retinal
I
detachment.
could help in this.
Yeah, of course.
I think the vitreous constant at this age, 40, 45, 40 to 50 years, it is different from that we have in the late ages. Why? You know, the liquefaction, you know, of the vitreous, this has helped a lot to protect the retina. So when you have the stereovitreous detachment that happened in the late ages, usually is, you know, more benign, and that could having less risk of peripheral retinal detachment, retinal breaks and retinal detachment. In the young age, you know, the vitreous is still compact, and that could be affected during this procedure, and that if anything happened, like, you know, vestibular capsule rupture, and then we have to that. I think this is from my perspective, assuming, you know, that's speculated like that. Yeah.
No, I agree. I thought I have a survival curve, but there's no actually survival curve there. So we know that actually as time goes, you get more retinal detachment. So I think if you started early, they will get the retinal detachment early. At least what we say. And also Dr. Hassan's give a beautiful explanation.
And I would like to, your comment is great, but let us to little bit modify it. Nowadays we have, you know, cataract surgery with multifocals, and there's a lot. Is that could affect the retina? Or your advice for this? Because now people
it does
they are
affect the retina. Yeah, it does affect the retina viewing, right? It also, if you have a patient with macular problem, they don't really get like an advantage of that lens, and also may make their life more miserable because they have macular problem. Now you're giving a lens that needs really good vision to benefit from. Otherwise, you get more blur. So I would say at least patients who have macular problem do not use multifocal
yes,
lens.
so that the contrast sensitivity is usually affected, and actually, you know, the peripheral view of this could be affecting their driving.
Yeah.
Dr. Kamara?
So just to follow, so specifically about like the aphthera lens, have you had any difficulty viewing the retina after the aphthera lens?
I honestly don't know. Is it a multifocal lens? I don't know.
It's considered pinhole optics for EDOF, but it has like a black donut in the middle. It doesn't have rings, so our retina colleagues say it doesn't affect too much. But I'm just curious if you'd seen it. Or
When I operate on patients with multifocal, it does affect my view, but I just get on with it. So I don't really like tell them like don't put it for this patient for retina surgery. I think it affects, but I think with the viewing system we have, we can manage.
Dr. Mutawih?
You know, sometimes we operate in one eye, the patient has no macular edema, but the other eye already received injection. Do you recommend to give prophylactic Avastin or anti-VEGF?
Yeah, I think my thinking of this, if you don't have a macular edema in this eye, just non-steroids will be enough. But if you have macular edema, I think this patient needs to be treated, whether pre or intra or post. And it's all fine. Sometimes you want to treat them pre, but the patients do not wants to go for cataract surgery. They want their vision to get better. So don't lose this patient, and I think you can treat them directly after or during the surgery.
Thank you.
I know that there is a catering outside, so please take Dr. Tahir, Dr. Rizwan.
I thought it was very interesting you mentioned about combined surgery and the odds ratio of 45 times risk of suprachoroidal hemorrhage. And for some reason, I've never been, lots of people are very keen on combined surgery here, but I've never been very keen on it, just for the intuition that if you have a problem following one surgery, it's easier to sort out. And if you have a problem following combined surgery, you don't know which factor might be contributing to the problem. And interestingly, we looked at a series of children here with suprachoroidal hemorrhage and found that combined surgery was a risk factor there as well.
That's very interesting.